Good morning, fellow learners. This is your mentor and your fact check buddy, Ray Gapus, once again joining you for a session in order to learn the secrets and the trends on the NCLEX-RN. So before we get to start the day, let us begin our session with some good news. And first, let me say congratulations to our recent passer, Alice Jeremy C. Amoroso of the University of Santo Tomas, who is now a USRN in the New York State Board of Nursing. She passed last July 30, 2021. Congratulations, Mom Alice. You are now a USRN, and we wish you well in your journey towards making that great American dreams to reality. Anyway, before we get to start, I'd like also to highlight certain emails that I receive. I'd like to share them with you because these are very, very inspirational. And when we say these are inspirational, it simply means that we identify ourselves with these kinds of issues or situations, okay? So it's coming from Lair, and she says, "Oh, it was the best review that I have taken. I really regret not knowing about this program months ago when I was starting to prepare for the test. Hopefully, I will be ready in the next 2 weeks. Thank you so much for all of your help." So she actually sent us a message asking if we could prepare a program for her in the run-up preparations for the NCLEX-RN because she has 2 remaining weeks and she doesn't feel confident about passing the test. So let's see what happened to her. So once again, she says, "Good evening, Ray. I'm a 4th-time test taker going on my 5th attempt in 3 weeks. I do not do the social media thing. I came across your page on YouTube last night and I have started with your QuickFix. Also downloaded your Kindle book. Listen, I have been discouraged. I have many challenges with studying. I have a full-time job and she is a single mother. I am not allowed to get time off before sitting the exam on the 19th. I have to travel from Bermuda to get to the USA. My first, second, and third attempts, I got all 265 questions. I took the exam in March 16 in reviews, but I still feel not ready. Some questions are still like, OMG, I never covered that. Need some advice of what I should do in such a short time left. Waiting for your response. Hope to hear from you soon." So we did some email exchanges all together. I created a program for her. It was a 5-day program initially, and then we stretched it to 7 days. It was very personalized. I implemented it together with the rest of the Gapus mentors in our team who are also very good. And so, as they say, eventually we built her confidence. And then this is the message I got from her after her test. And she says, "Good day to my Gapus Mentors family. Firstly, I want to thank you for all the tiring hours that you have spent with me for the past 3 weeks. All of you have been nothing but positive mentors and provided extraordinary guidance and support towards my success. During the few weeks, you have helped me build up my confidence in taking strategies and knowing my content. You have also helped me to look within myself and heart, reminding me of what I wanted most, which was to become a registered nurse. Although this has been a long journey for me, you guys are the real deal, and I would recommend you, anyone, to get help you need from Gapos Mentoring. You guys are family. And I truly appreciate you, Ma'am Jem. Special mention for Mentor Jem. Thank you for the final words of encouragement, Ma'am Jane." Ma'am Jane this is Jane, Ma'am Jane. "You have been remarkably prompt with your responses in whatever time of the night. Thanks for sending me the materials on time. Also, shout out to George, of course, our IT support, and of course, Mentor Ray, who has provided this wonderful program. I will continue to watch your YouTube channel to help me with upcoming information. Love you guys always and forever." And she sent us the person view result that says she has a passing result. It's just unfortunate that it was cut off, okay, on this email. So congratulations, Lair. And of course, in as much as we would want to share her personal details, well, she signed up and told us about she would prefer just us sharing these email exchanges to inspire others and leave her personal details to herself. And so therefore we respect her privacy as much as we do. Most of our passers would usually opt not to be posted. But for those who really want to share to the world their inspiring journey, I encourage you to do the same and share with us your story. So after watching this quick fix number 21, we are now on our quick fix number 21. I just hope that most of you guys would be able to get the focus that you are yearning for. So always remember, just like Lair, problems are not stop signs, they are guidelines. That's according to Robert Schuller. Once again, we repeat, problems are not stop signs, they are guidelines. In essence, if we meet some bumps or humps along the way, these are just situations that are telling us to either slow down and look at ourselves, look at the help that could be available around us. And don't forget to hit and press that bell notification button, like and share our videos to your friends. Those who will do it now will pass the NCLEX with a minimum number item of 75 and in the shortest possible duration of time. And if you share this to 10 of your friends, you will receive extra blessings. Okay, so that's what we would want you to do. So you can like and share our videos to your friends so that we'll be able to help them out too. Okay, so for those of you who are still having difficulty on which program to take, I'd like to invite you into my 45 days Power Pack exclusive NCLEX-RN test preparations. I will be the main mentor for these 45 days Power Pack exclusive NCLEX-RN test preparations. You don't have to leave your work because this is a very flexible program. Okay, so if you're interested, just send us an email, which I'm going to present to you after our class today. So for those of you who are asking me which book is best to read if they just have like 1, 2, or 3 weeks left before the NCLEX, I would recommend NCLEX 311. It contains the 311 functional concepts that you need to remember for your test. So if you have questions, send me your questions through this email, mentor.raygapos@gmail.com. So let's begin without further ado for session number 21. And there's no other way to start our session but to begin with the concept of prioritization. Now take note. Some of the questions, although related to prioritization, could be answered using strategies that I have discussed with you previously in our quick fix videos. At this point in time, I'd like to tell you that the current trend would be integrating strategies with content knowledge, which means even if you know the strategy, if you don't know what topic to discuss, then the strategy becomes useless. And this is where your functional concept could come in, because the functional concepts method integrates both strategies and content into a specific framework, such that you are able to analyze and at the same time utilize your stock knowledge as you answer questions on the NCLEX-RN. So let's begin with this question. The nurse is providing discharge instructions to a client who is taking linezolid. Which of the following statements of the client would the nurse address first? Okay, if you don't know what linezolid is or you don't know what Civox is, it would be very difficult to answer this question. Well, linezolid is actually an antibiotic. It has antibacterial properties, and this is used to treat infections. However, this medication, since it changes the pH of the GIT, we expect that there will be diarrhea. So there's no need to address number 1 first. Let's take a look at number 2. I will need to tell my healthcare provider if I will be prescribed fluoxetine. Well, fluoxetine is Prozac. It's a selective serotonin reuptake inhibitor. Now, what's the implication of Prozac when it's combined with linezolid? There is a chance that serotonin syndrome could develop, in which case the vital signs would go up and the patient may experience neurological signs and symptoms, okay? So we can consider number 2. 3, I can continue taking this drug with my newly prescribed insulin. Okay, your insulin causes hypoglycemia, and linezolid also could cause hypoglycemia, okay? And number 4, I will need to call my healthcare provider if I experience bleeding. Well, that is necessary because your linezolid could cause myelosuppression, so it decreases the WBC, RBC, and the platelets. Therefore, we are torn between number 2 and number 3, okay? So if the patient would say, I will need to tell my healthcare provider if I will be prescribed fluoxetine, and number 3, I can continue taking this drug with my newly prescribed insulin. So now that we are torn between number 2 and number 3, we need to refer back to the question. And the question is asking us, which should we as a nurse address first? So it simply means that you will need to address something that needs to be corrected. So number 2, I will need to tell my healthcare provider if I will be prescribed fluoxetine. This is a proactive attitude of the patient. Maybe she was told during discharge instruction that linezolid could potentially cause serotonin toxicity when taken with a selective serotonin reuptake inhibitor like fluoxetine or Prozac. But take a look at number 3. I can continue taking this drug with my newly prescribed insulin. This indicates knowledge deficit because your linezolid could worsen the hypoglycemic reaction that could occur and develop in a client taking insulin. Now, how would we know that the patient is having hypoglycemia? Well, the patient will have diaphoresis, difficulty in problem solving, dizziness, and drowsiness. Your 4Ds. Once again, diaphoresis, difficulty in problem solving, dizziness, and drowsiness. That would make you suspect that the patient is indeed having a hypoglycemic reaction. So the answer is definitely number 3. Okay, so let's focus. So remember, linezolid may cause thrombocytopenia, which simply means there's going to be a risk for bleeding. So you need to check the client's platelets, which is the normal would be 150,000 to 450,000. So one of your priority nursing diagnoses would be risk for injury because of the potential for bleeding. Second, linezolid may cause hypoglycemia, so you need to check the blood sugar level of the patient. And of course, you will have to know that when the patient's sugar level falls below 50, then you are having a severe hypoglycemic reaction. The normal sugar level should range from 70 to 110. 126 could be bordering hyperglycemia. Okay. Linezolid may cause serotonin syndrome in a client taking selective serotonin reuptake inhibitors, just like your fluoxetine or Prozac. So this is what happens when your patient develops serotonin syndrome. Don't forget, our code is actually cramps. Okay, so here we go. The code is cramps. So C would mean confusion. So the patient would be unable to determine where he is or she is, and then there's going to be a difficulty in identifying the date, the time of the day. Then the vital signs, specifically the heart rate and the blood pressure, would go up. Then the patient will become anxious and restless, that's agitation, and the muscle will twitch, and it is coupled with muscle rigidity. Then the 3Ds occur: diarrhea, diaphoresis, and dilated pupils. You know for a fact the diaphoresis of the patient could be related to your CNS or autonomic nervous system stimulation. Okay, and then the client shivers. So try to imagine that a patient with serotonin syndrome is someone who is ill, like patient with fever, okay, in which the heart rate could go up, okay, and then there's going to be shivering and diaphoresis, okay. Then eventually the central nervous system is affected, so the patient may have confusion, agitation, then muscle twitching and rigidity. So remember, cramps. Okay, so let's move on. Let's try using that concept to answer a sample question. Which of the following manifestations occur in serotonin syndrome? Heavy sweating, yes, that's diaphoresis. Headache, yes. Goosebumps, yes, that occurs with the activation of the autonomic nervous system. Constipation, no, we said it should be diarrhea. And hypotension, no, it should be hypertension. Now, if you'll be asked, which specific vital signs should you focus on when you're assessing a patient for serotonin syndrome? Focus on the heart rate and the blood pressure, which will both increase. Okay, so now let's move on to delegation. Now, I've been receiving a lot of questions through my email about delegation, and let me clarify some of these questions through the use of our functional concept. Remember this, the RN may oversee the execution of tasks to the unlicensed assisted personnel related to gastrostomy tube maintenance, feeding, and administration of prescribed medication. Now, take note, if the RN may oversee the execution of tasks, therefore, the RN may delegate the execution of tasks to the unlicensed assisted personnel. So those who are asking if the UAP could administer gastrostomy tube feeding or G-tube feeding, as well as the administration of prescribed medication through your G-tube, well, the answer based on this document from Maine.gov is yes. Okay, so the Maine State Board of Nursing issues this position statement to guide the practice of nursing. So the board's primary concern is the health and safety of consumers. So this is related to the role of the registered professional nurse in the coordination and oversight of unlicensed assisted personnel regarding gastrostomy tubes or G-tubes. Okay, so the registered professional nurse may coordinate and oversee the task of G-tube care to unlicensed assisted personnel in populations with developmental disabilities. In certain circumstances, the RN may coordinate and oversee the execution of tasks related to G-tube maintenance, feeding, and administration of prescribed medication. There you go. This official document answers your question. So will you include that? Therefore, if you have a select all that apply type of question, yes. Okay. Next. Now, for those of you who might be saying that previously it wasn't allowed, but you have to know that the concept of delegation is evolving as more and more unlicensed assisted personnel are provided with training to empower them to properly assist the LPN, the LVN, or the RN. So you have to know that as this evolved, we will have to update ourselves. So we're not saying what were previously taught were wrong. We're not saying that, but there are modifications that are being called for the unique times we are in at the moment. Next, there's another functional concept. Unlicensed assisted personnel who are trained can administer suppository and enema medication. So pay particular attention to this class. So even if the administration of enema medications require a doctor's order, trained and licensed assisted personnel can administer them. So here is actually the document from the North Carolina Board of Nursing that specifies delegation of medication administration to unlicensed assisted personnel, specifically your rectal suppository and enema administration. So note here, the RN or LPN is permitted to delegate only after application of all components of the North Carolina Board of Nursing Decision 3 for delegation to unlicensed assisted personnel, and after careful consideration that delegation is appropriate for the client, okay, with the acuity level, with the individual UAP's knowledge and experience, and within the period of time. So take note, the RN or the LPN can now delegate rectal suppository insertion and enema administration through your unlicensed assisted personnel, provided this criteria are met. Okay. Unlicensed assisted personnel can administer COVID-19 vaccines. Okay. So once again, from the North Carolina Board of Nursing, here's a COVID-19 vaccine advisory. And let me read it. North Carolina is in the process of preparing for massive administration of COVID-19 vaccine. Declared state or national emergencies or mass immunization campaigns may require the immunization of large numbers of citizens within a short designated time period. At such times, it may be necessary and appropriate for nurses RNs and LPNs to delegate the task, take note, to delegate the task of immunization administration consistent with agency policies and procedures to unlicensed assistive personnel as part of the timely, effective mass immunization program. Okay, so it is very important for you to know this. You can delegate the administration of vaccines to your unlicensed assistive personnel. And pay particular attention to this fact also that the delegation of vaccine administration to UAP, it is crucial that nurses and UAP receive the appropriate education and training, and they should be validated as competent. And they should maintain compliance with agency and facility policies and procedures. Okay, so here we go. Let's try to use the things that we learned to answer this question. Which of the following tasks can be delegated to the unlicensed assistive personnel? Okay, let's begin. Administration of COVID-19 vaccine, yes. Insertion of rectal suppository, yes. Administration of enema, yes. Administration of medication through gastrostomy tube, yes. Administration of subcutaneous heparin. Now take note. Okay, if your patient is in a home care resident setting, it is allowed that the unlicensed assistive personnel administer subcutaneous insulin. But that does not mean that the unlicensed assistive personnel is allowed to administer any and all drugs that are given subcutaneously, because there are drugs that they cannot administer even if it's administered subcutaneously, and these drugs are called high-risk medications. And one of these would be your anticoagulant, that's your heparin. So even if the unlicensed assisted personnel in a home care setting is allowed to administer insulin subcutaneously, your unlicensed assisted personnel is not allowed to administer your subcutaneous heparin. So that's an X. So I just hope you are able to remember this. So let's move on. Now, our first focus for our quick fix would be your benign prostatic hypertrophy. Pay particular attention to the fact that your BPH is common among patients who are above 50 years old. So patients with increasing age are more at risk for BPH, of course. Okay, the exact cause is unknown, but take note of this fact that the incidence of benign prostatic hypertrophy increases with age. In fact, 90% of those who are above 80 years old would have it. And take note also of the fact that those who had orchiectomy usually do not develop your benign prostatic hypertrophy. Now, if you talk about the common signs and symptoms, we're going to compare BPH later on with prostatitis, so that when you are given the opportunity to answer questions related to that, it's not going to be difficult for you. So remember that in benign prostatic hypertrophy, because of the enlargement of the prostate, which could be compressing, okay, the urethra where urine would pass out, then there's going to be frequency of urination, urgency of urination, decreased size and force of urinary stream, and increased urination at night. Now, one of the important things that you have to remember would be, is hematuria a sign of BPH? If it is a sign, yes, but when does it occur? It usually occurs late in the disease. So if the question is asking about early signs, then you don't put a check on hematuria. But if the question is asking about late signs, then you may want to put a check on hematuria. Now, one of the common drugs that is usually given for clients with BPH would be your finasteride. Okay, your finasteride is your alpha reductase inhibitor, and it acts in three ways. First, it increases testosterone. Second, it decreases the prostate gland. And third, it increases hair growth. Therefore, okay, your finasteride could be used to treat hair loss. However, there are also studies that say that the use of finasteride can potentially cause breast cancer in males. So that when your patient is taking finasteride, instruct them to report breast lumps or the presence of breast discharge or the presence of any pain and tenderness. So what is important that you have to pay particular attention to at this point would be knowing specific functional concepts related to your BPH. So let's begin by trying to answer a simple question. In a client with benign prostatic hypertrophy, which of the following substances may worsen the symptoms? So we talked about the symptoms early on. Diuretics, yes, that may potentially worsen, specifically nocturia. Tricyclic antidepressants may cause anticholinergic side effects, which leads to urinary retention, so it could worsen, okay? The difficulty of the patient to urinate. Antihistamine may also cause urinary retention. So yes, coffee, yes, may worsen nocturia at night. Okay, finasteride would usually help diminish your signs and symptoms. So it is an X, okay? So for your patients with benign prostatic hypertrophy, pseudoephedrine should not be given, and the drugs that may usually have your anticholinergic side effects, because this could cause urinary retention. Like, for example, atropine could also cause urinary retention. Okay. Next, let's try to compare your prostatitis, which is inflammation of the prostate, and benign prostatic hypertrophy, which is enlargement of the prostate. Let's take a look at the risk factors that are common to both. Now, this is what is funny. Both could be associated with urinary tract infection, and prostatitis is a risk factor for BPH, and BPH is a risk factor for prostatitis. Okay. So that leads us to think that if a patient has prostatitis, they could be at risk for BPH, and if a patient has BPH, they could be at risk for prostatitis. Okay. Now, rectal intercourse is a risk factor for prostatitis, including dehydration and pelvic trauma. On the other hand, okay, the other risk factors for your BPH would be urethral stricture, presence of kidney stones, cancer of the prostate or the bladder, as well as aging, family history, the presence of diabetes mellitus, and obesity. Look, as if I'm trying to move towards that, but I just hope I won't have it. Okay, so the most important thing, therefore, that you have to remember here is what risk factor could be common to both, and that's going to be your urinary tract infection. Okay, now which one is usually associated with family history? That's going to be your benign prostatic hypertrophy. Which one is expected with advancing age? Benign prostatic hypertrophy. Which one is associated with diabetes mellitus and obesity? It's going to be benign prostatic hypertrophy. Okay, so remember this functional concept. High fever occurs in acute bacterial prostatitis and not in benign prostatic hypertrophy. So if you are to be asked which symptom would differentiate acute bacterial prostatitis from benign prostatic hypertrophy, it should be high fever. Therefore, you need to monitor the patient's temperature, okay, to check whether the patient is having prostatitis or benign prostatic hypertrophy. So if the patient presents with, say, for example, urgency, hesitancy, and nocturia, and then it comes with fever, then suspect prostatitis. Without the fever, then suspect your benign prostatic hypertrophy. Now take note, weak urine stream occurs in both prostatitis and BPH. So if you are asked which risk factors occurs in both BPH and prostatitis, that's going to be urinary tract infection. Which symptom occurs in both? That's going to be weak urinary stream or decreased size and force of urinary stream. Which symptom differentiates acute prostatitis from benign prostatic hypertrophy? That's going to be high fever. Okay, so let's try answering a question. Prostatitis can be diagnosed by which of the following tests? Urinalysis, ultrasound, cystoscopy, prostate biopsy, yes. Digital rectal exam and prostate massage, yes, that's also done in the assessment for benign prostatic hypertrophy. Complete blood count, that is done to check whether there is an infection. Remember, prostatitis is caused by a bacteria. And then prostate-specific antigen test and CT scan, that's actually to rule out the presence of benign prostatic hypertrophy, yes. Biophysical profile is not a test for prostatitis. Your biophysical profile is a test in the newborn baby if you want to determine, okay, the fetal breathing, fetal movement, reaction to non-stress test, amniotic fluid volume, and your overall physical health of the baby. So in essence, the most important criterion in biophysical profile would be your fetal breathing movement. Okay, so fetal breathing movement, okay, fetal heart rate, fetal movement, fetal breathing, fetal movement, fetal heart rate, non-reaction, reaction to non-stress test, and then your amniotic fluid volume. Okay, so it's done to assess the infant at birth. Okay, so if you want to find out the fetal well-being, okay, immediately after delivery, then that's the test that's done. That's your biophysical profile. Okay, so remember, prostatitis can lead to infertility, sepsis, and even death. Now, let's resolve this issue. Previously, let me just update you about saw palmetto. Previously, it has been recommended that saw palmetto, which is an herbal remedy, the picture is here, could actually help diminish the symptoms of benign prostatic hypertrophy because your saw palmetto is believed to cause atrophy of the prostate. That was before. However, at this point in time, saw palmetto, the effects in terms of the atrophy of the prostate, okay, in the studies that were done, there are contrasting results. So can we categorically say, therefore, that saw palmetto is 100% effective for the treatment of BPH? No, we can't. But we can tell our patient, we can cite that there are studies that identified the effect of saw palmetto in terms of promoting atrophy of the prostate, but there are also studies that yielded contrary results. Okay, so therefore, okay, it's very important that we inform our clients about this development. Okay, so saw palmetto eases urinary difficulty in clients with BPH by preventing its progression. Other uses includes, aside from BPH, would be your asthma. It's used also as diuretic. It's used in cough, as astringent, and in clients with bronchitis. So let's try answering a sample question and use what we just have learned. A client with benign prostatic hypertrophy, okay, ask the nurse if taking saw palmetto will help improve the symptoms. The knowledgeable nurse will give which of the following responses. Let's analyze each of these. The way to answer this question is not to rush. I advise you to take it slow, okay? Comprehend each option, even if you already have in mind a potentially correct answer. Do not let that drive you into rushing to choose a specific question. So let's analyze. One, you will need to take it for a couple of weeks to know if it improves your symptoms. Treatment with saw palmetto would usually take 4 to 6 weeks. Okay, so however, does it address, okay, the question of the client related to the management of the symptoms? I don't think so too. There have been studies that say it is effective and some studies say it's not. You can discuss this with your healthcare provider. We can consider that. It's open-ended. 3, I understand your concern. The pharmacy can best explain it to you. That's passing the bat. And 4, herbal remedies in general have no therapeutic effect, so it is best to avoid it. I think that reflects a personal bias. And so the best answer, therefore, is number 2. There have been studies that say it is effective and some studies say it's not. You can discuss this with your healthcare provider. Okay, now, another thing that we need to be focused on if you are studying for the NCLEX at this point would be your Alzheimer's disease, which is a form of dementia. Now, is it enough to just focus on Alzheimer's disease? I would advise you no. Try to study Alzheimer's and try to study other forms of dementia, like, for example, frontotemporal dementia, like your Pick's disease. Okay, and then try to identify the similarities, the way that we did it for prostatitis and BPH, and the differences. So what is important, therefore, is that you know what Alzheimer's disease is. Okay, so the main problem in Alzheimer's disease would be the development of senile plaques, okay, that could be associated with the presence of your amyloid. And this leads to the destruction of the neurons that secretes acetylcholine. So once acetylcholine is decreased, learning and memory also decrease. Now take note that your acetylcholine is responsible for preservation of memory. Okay, So let's pay particular attention to these functional concepts. First, a protein called amyloid beta is the hallmark of Alzheimer's disease. Okay, so which means it is the diagnostic marker for Alzheimer's disease. So genetic tests can help diagnose Alzheimer's disease because they have found a potential familial predisposition or genetic predisposition to Alzheimer's disease. Well, it could sometimes be genetic, or sometimes it could be that because the same family members stay in the same environment, then there could be an exposure to substances, like some studies identified aluminum that is accumulated in the brain. And if one family could be diagnosed, all members could be diagnosed with Alzheimer's disease. They could be using the same utensils, they could be staying in the same location where there's a high concentration of aluminum. So it needs more validation to say that it could be associated with environmental factors as well as genetic factors. However, genetic tests can help diagnose Alzheimer's disease. Memory loss is the key symptom of Alzheimer's disease, but this is very difficult to identify because most of us would usually associate memory loss with normal aging. We think that this is expected when your patient is growing old. But remember this class, remember this functional concept. Cognitive deficits are not expected as you age. So it simply means you're not expected to forget things when you grow old. Although most of us would say, oh, I forgot my appointment, I'm getting old. That could be our personal belief. But for some, could be beginning signs of Alzheimer's disease. I'm not trying to frighten you, but what I'm trying to say is it is a possibility. Okay? Now, your Alzheimer's disease could begin with mild cognitive impairment. So the initial stage would be your MCI, mild cognitive impairment. And I created a code, also MCI, okay, which stands for memory changes. So frequent forgetfulness, cognitive impairments, okay? So they forget details of the conversation and they would say, you didn't tell me that, even if you told them about it. Impaired ability to recall details of conversation, recent events, or appointments. So loss of memory of recent events, that's your anterograde amnesia, okay? Or this could be inability to learn new things. You just taught them how to do something and then they immediately forget it. So they used to be fast learners and they eventually become slow learners. And sometimes we attribute this to aging. So mild cognitive impairment may not necessarily be noticeable, especially for those who are not trained to identify these kinds of things, okay? They think it's a normal part of aging, but it's not. These are all beginning signs of Alzheimer's disease. Now, mild dementia due to Alzheimer's disease is characterized by, okay, mild dementia. Okay, this is now your mild Alzheimer's disease. So you have the code mild. Memory loss of recent events, okay, or anterograde amnesia, increasing difficulty with problem solving or complex tasks and judgment. A common manifestation of this is that they will have difficulty balancing checkbooks. They are issuing and issuing and issuing checks, even if they no longer have money in the bank, okay? Now, there's also loss of previous functions, or there's reduced motivation, okay? Avolition, that's a medical term, social withdrawal, and aphasia. Aphasia is inability to find the right words to say, okay? That's expressive aphasia. They are unable to find the right words to say, or they have difficulty identifying the words, and sometimes they have difficulty understanding spoken words. So that's receptive aphasia, okay? Now, your aphasia does not just occur in Alzheimer's disease. It also occurs in frontotemporal dementia, okay? Because in frontotemporal dementia, the frontal lobe and, okay, including the Wernicke's area in the temporal area, okay, the Broca's area and the Wernicke's area are affected. And so the patient may also have expressive aphasia or Broca's motor speech aphasia and Wernicke's aphasia due to the affectation or receptive aphasia due to affectation of the Wernicke's language area and the area of comprehension in the temporal lobe of the brain. Now, D, diminished ability to organize or they usually get lost, okay? And then they misplace belongings. Now, the difference of a patient with Alzheimer's disease to that of a patient with frontotemporal dementia or fixed disease is that for patients with Alzheimer's disease, they get lost even in familiar environments. That's why when they are in the unit, we never ask them to wear shoes because they would think that they are going somewhere, and that increases wandering. So it's very important that when they are in the unit, we allow them to use slippers instead. Okay. For patients with frontotemporal dementia or fixed disease, okay, their spatial orientation, meaning orientation as to space, orientation as to where they are, is usually intact. So they don't get lost in familiar environments. That's your fixed disease or frontotemporal dementia. And those who usually get lost in familiar environment are those who are having Alzheimer's disease. So it's very important, since these are cognitive impairments, your priority should be to frequently reorient the patient, okay? And sometimes they have a tendency to misplace their belongings. So you would see the car keys inside the fridge, or you would see their wallet, okay, inside the sink. So this could be common observations for patients with Alzheimer's dementia. Then moderate dementia due to Alzheimer's disease is characterized by moderate, okay? Moderate dementia, moderate. Okay, what are these? Memory loss, like confabulation, or they make up stories to fill in memory gaps. So since they have forgotten the details, they create stories to bridge their memory gap. Okay, now this is actually to protect their self-esteem. So we allow them to confabulate, allow the patient to do that. Now, they also have inability to recall personal history. They don't know who they are. They don't know where they're from, including their phone number. So it's very difficult, especially for patients with wandering. Now, they could also have outbursts of aggressive physical behavior. So they act out, and this could potentially lead to a violent reaction. So it's very important that we manage this and avoid agitating the patient. Deepening confusion. So they will become disoriented as to time, place, and person. So initially, they don't know what the time is. They don't know where they are. Then eventually, they are unable to recognize the nurse. So you always have to introduce yourself and tell them your role. And then this is the time when wandering occurs. So they walk and walk and walk until they go to and reach a specific place, and they don't know where they are. Okay, they would also have exaggerated or unfounded suspicions. They think that a family member is getting money from their bank account. They accuse their husband or wives of having affairs. And sometimes they have a tendency to believe that these are real. So it's very important for the nurse to know that this could be unfounded suspicions. Okay. Patients in the moderate stage of dementia love to repeat their favorite stories. So you would usually hear them talk about these stories over and over and over again every day. So they talk about their dog. They talk about how they used to be admired by a lot of people once again. And sometimes you would note that their stories would have different versions because they are having memory gaps. So they are just trying to confabulate to fill in the memory gaps. And then they would usually have agitation, which means they're having anxiety and restlessness late in the day, especially when the sun sets. So we call this your sundowning syndrome. So confusion that increases as the sun sets is what we call sundowning syndrome. Confusion that occurs as the sun rises in the morning is what we call your sunrise syndrome. So whether you're having sundown or sunrise syndrome, there will be disorientation. So it's very important. Your priority is to orient the patient. And then eventually they will have troubles with activities of daily living. So they will have bowel and bladder incontinence. So you have to assist them with bowel and bladder elimination. And then take note, they will also have difficulty choosing the right clothes for the weather. So sometimes they would wear sleeveless shirts during winter, and during summer, they would wear their leather jacket. So if you see an old patient wearing a leather jacket during summer, suspect Alzheimer's. But if you see a Filipino, not old, but wearing leather jacket during summertime, he's the action star in Philippine movies. Okay, and then they usually would experience visual and auditory hallucination. Now, this is very typical with patients with Alzheimer's disease. Look, they have exaggerated or unfounded suspicions, which could be a false belief. So it's a delusion. And they are also having hallucinations. So sometimes patients with Alzheimer's are given antipsychotics because they are having delusions and hallucinations. Okay. Next, severe dementia due to Alzheimer's disease is characterized by, take note, severe. They speak incoherently, speaks incoherently. So they themselves will not be able to understand what they're saying. Then they have extremely rigid muscles, which could be mistaken as symptoms of Parkinson's disease. The vocal cords get weaker, so their voice could be softer, and then excessive difficulty and loss of ability to swallow. So that makes them at risk for aspiration. And then eventually, in the severe stage, they require total assistance with bowel and bladder elimination and all activities of daily living. And then they experience a decline in physical abilities, like difficulty walking, they're unable to sit. So you will have to assist them regularly. So let's try answering a sample question. Which of the following interventions are appropriate for patients with Alzheimer's disease? Select all that apply. Okay. Provide some choices every day, like asking the patient to choose from 2 outfits. Yes. This would enable them to exercise making a decision. Okay. However, you have to limit the choices to 2. Do you want the black or the white? Do you want coffee with cream or without the cream? Not too much choice, because too much choice could agitate the patient because they get pressured for making a decision. Use clear one-step communication. Yes. Okay. Limit daytime naps. Yes. Otherwise, the sundown syndrome, that is agitation and confusion that occurs when the sun sets or at nighttime, could be aggravated if you don't limit daytime naps. So yes, we put a check. Turn off the TV at mealtime so they get focused. They don't get overloaded with stimulus. Yes. Consider buying identical outfits if preferred by the patient. Some patients, especially the elderly, would want the same set of shirts, the same set of shoes, the same set of underpants. Then you comply. Okay, because even patients with no Alzheimer's disease do that. I myself do that. I have several pairs of my favorite shirts because I love the fabric, and the same is true with them. Stick to bathing schedule even if it's met with resistance. Now take note of that. Some of them may forget that they have taken a bath. You would see them naked and they have taken a bath an hour ago. So you always have to assist them and say, if you feel dirty, I will have to assist you in washing yourself, or present reality, tell them that they have taken a bath an hour ago, but if they still feel the need to wash, then they can be assisted. But do not be too rigid with schedules, especially if it is met with resistance. So this is an X. Okay, so what are the drugs for clients with Alzheimer's disease? So you have your cholinesterase inhibitors. This drug prevent the destruction of acetylcholine. So in essence, it helps decrease the signs and symptoms. So you have your donepezil or Aricept, galantamine or Razidine, and rivastigmine or Exelon. You have the code ARE. So it will help improve agitation and depression. So the common side effects would be insomnia, nausea, anorexia, diarrhea, and a potential cardiac arrhythmia. That's why you have to check the heart rate. And then you have your memantine or Namenda. Okay, what is memantine? It's an NMDA antagonist, which simply means NMDA is N-methyl D-aspartate receptor antagonist. What does it do? So your memantine blocks glutamate. Okay, glutamate is found in clients with in the seasoning that we do. Remember your MSG, in the Philippines we call it betchin, monosodium glutamate. Okay, your glutamate is a substance that helps facilitate learning and memory. Okay, however, why do we need to block glutamate? Because when there is excess glutamate in the brain, it overexcites the nerve cells in the brain, the neurons. And when the nerve cells are overexcited, it could lead to rapid death. And that accounts for the loss of memory and the inability to learn new things. That's the reason why people were saying MSG, too much use of MSG could lead to Alzheimer's disease. Well, it could be a possibility. Now remember that your memantine is not a cure. It is given to slow the progression of symptoms or to treat the confusion. Okay, so the common side effects would be dizziness as well as confusion. Okay, so what is actually funny here is that memantine is used to slow down the symptoms, including confusion, but a common side effect would also be confusion. But sometimes, okay, the use of the medication outweighs those side effects. Okay, so let's move on. Now let's talk about hallucinations. I have a question that I'd like to pose to everybody. Do you think that all types of hallucinations are abnormal? And do you think that hallucinations are only found in clients with dementia or psychosis? No. We have what we call hypnagogic hallucination. Now, hypnagogic hallucination is a type of hallucination that occurs at nighttime whenever we're about to sleep. And sometimes this could be in the form of sounds or sensation, like we feel something, okay, cold, or we hear some sounds, okay? So this is hypnagogic hallucination. So it's expected, and it could be associated with a decreasing level of consciousness that we have as we begin to fall asleep. Now, when we get awakened in the morning, we have hypnopompic. That's called hypnopompic, P-O-M-P-I-C. So M, morning. Hypnagogic, nighttime. Hypnopompic, it occurs in the morning as you wake up. Okay. And of course, this could also be false sensory perceptions. Okay. Now remember, in hallucination, a client perceives something that is not there. Okay. So your nursing diagnosis would be altered sensory perception. And you have to specify if the patient is having auditory hallucination, then say auditory. If the patient is having tactile hallucination, then say tactile. Tactile hallucination is described as a patient who is alcoholic, having alcohol withdrawal syndrome, feels like bugs are crawling in the skin, or sometimes they fear, okay, but when the lights are off or they are in a dim lit room, okay, they see monsters. Okay, that's visual hallucination. So if they're hearing something, auditory hallucination. If they're seeing something that's not there, visual hallucination. If they're feeling something that is not there, tactile hallucination. In the alcoholic patient, it's either they have visual hallucination. That's why you have to provide them well-lit room, and tactile hallucination. That's why you have to tell them that you don't see bugs crawling on their skin in order to decrease agitation. So it's very important that you deal with this. Otherwise, the hallucinating patient could become agitated. So always present reality. Acknowledge that for the patient, what they hear, what they see, and what they feel could be real, but it's only real for them. Okay? So acknowledge that it's real to the patient, but it's not real to the nurse. So you're trying to differentiate subjective reality, which is what is real for the patient, and objective reality, which is what is real as the nurse sees it. Okay, granting that the nurse is not also having alcohol withdrawal. But what if both of them are having alcohol withdrawal? So whenever the patient says, I'm hearing voices, so what will be the response of the alcoholic nurse? Will the nurse say, I'm hearing it too? Okay, just joking. Okay, so let's move on. So let's try answering a simple question. Which of the following interventions are appropriate for patients with hallucinations? Select all that apply. Call out the client's name. That could have been correct, but look at the last word loudly. This would agitate the patient, so we put an X. As the client, if he is afraid, yes, you need to process the patient's feelings. That's correct. Talk with the client about the experience. Yes, it would desensitize the patient. It will have a cathartic effect, emotional cathartic effect on the patient. Introduce activities to the client. This is considered as a diversionary tactic for the patient. Okay, then yes, tell the client to say go away to the voices. Now, you would notice that it's when the patient is alone and they're not busy, they're not talking to anybody, and their mouth are closed, that they would usually have increased auditory hallucination. Why? Well, a psychiatrist said that because the patient is by themselves, okay, they usually don't have any other choice but to self-talk, which occurs in normal individuals. But for patients with psychosis, okay, they project certain things that they cannot accept within themselves through auditory hallucination. So instead of saying, I killed my neighbor, then they would usually say, I'm hearing a voice that says, he killed my neighbor. So that's their coping mechanism. And they are unable to do that if we keep them busy or if their mouth is open. They can only whisper to themselves when their mouth, okay, are close or they're not talking to anybody or they are alone. Okay, so tell the client to say, go away to the voices. This would um, bring into their consciousness that they are indeed having a manifestation called hallucination. Suggest to avoid watching TV or listening to music. No. It's all right for them to watch TV as a form of diversion, to listen to music as a form of diversion. And it is not a general intervention for us to say that they have to avoid watching TV or listening to music. Okay? Now, also, I received this message from my messenger, okay, and he says, salamat sa QuickFix, Nong. Thank you to the QuickFix. And I asked, anong QuickFix ang nakahelp sa'yo? So what QuickFix helped you the most? And he said, 12 and 15, including those with delegation. So QuickFix 17, 18, 19 covers the delegation, which are very updated, including the delegation, the principles of delegation that we just discussed today. So always remember, you may encounter many defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeats so you can know who you are, what you can rise from, how you can still come out of it. That's according to Maya Angelou. Okay, so just persevere. Eventually, God gives you what you want at the most appropriate time when you can best appreciate it. So failure is never the opposite of success. It is a part of success. And if you want to succeed, you have to double your failure rate. Commit all your failures as you are watching our videos. Commit all your failures in your classes. Okay, what matters is eventually come out of it successful. Now remember, at this point in time, do not put yourself into a very exclusive zone. If some tools would really help you, then use it. Okay, if you find a site that can help you, use it. If you find our videos helpful, use it. So that's the trend now. It should not be that, well, I just would want to use one. No. Okay, there is no one thing that can address every learner's needs. And that's the reason why these free videos are designed to help you out. And we have a lot of testimonials telling us that they passed the test by merely watching our videos. Okay, so next, let's talk about thalassemia. Now I have a question about thalassemia. Is it all right to, since thalassemia leads to anemia, why is it not appropriate to administer iron? Well, because in thalassemia, the cause of anemia is a defect in the alpha and the beta chains of the hemoglobin or the RBC. Therefore, it leads to destruction of the red blood cells. And when the red blood cells are destroyed, you have a separation of the iron component, which is your heme, and the protein component, which is globin. Now, when the excess heme accumulates under the tissues of the patient, then you will have hemosiderosis, which could lead to iron poisoning. So hemosiderosis is accumulation of iron in the tissues. That's the reason why we do not give iron in patients with thalassemia. We give them the antidote for iron poisoning, which is deferoxamine, okay? And instead of iron, they are given blood transfusion, okay? So thalassemia is an inherited blood disorder, autosomal recessive, which means both parents have to be trait carriers so that 25% of their children will have the chance to develop the disease and 50% chance of carrying the trait. In thalassemia, RBC breakdown occurs, leading to anemia. Now, thalassemia occurs in, remember, Gamies, Greeks, Africans, Middle Easterners, Italians, South Asians, including me. I'm a Filipino and a South Asian. So the main problem in thalassemia would be a defect in the alpha chain in the hemoglobin, as well as the beta chain in the hemoglobin. Okay. And here's a question. Can a person have both beta and alpha thalassemia? Yes, about 10 to 20% of patients with beta thalassemia also have alpha thalassemia trait. And take note, prenatal testing for thalassemia include chorionic villi sampling and amniocentesis. Now, both of these
Diagnostic tests are ultrasound aided. So the nurse has to check whether the ultrasound machine is working properly before the test is done. Okay, now, in order to promote visualization, okay, instruct the client not to void. If, okay, this is done usually in the first trimester. Now, your chorionic villi sampling involves the aspiration of a part of the placenta known as your chorionic villi, and the placenta develops between 8 to 10 weeks. That's why your chorionic villi sampling is usually done between 10 to 12 weeks. It can be done earlier. That's its main advantage over your amniocentesis. Your amniocentesis is usually done either in the second or the third trimester. So in the second trimester, your amniocentesis is done to determine the presence of chromosomal abnormalities, whereas in the third trimester, your amniocentesis could be done to determine fetal lung maturity, especially if the LS ratio is tested after the procedure. So what is important for you to note is that since both tests are invasive, so you need to verify if the patient has the consent. And then after the procedure, it could lead to IBAF. What is it? Infection, bleeding, potential abortion, and fetal death. That is why it's very important that you have to check the patient after the procedure, because those complications could develop. Okay, mild forms of thalassemia trait don't require treatment. So what are the treatment for thalassemia? I said no iron. We give them frequent blood transfusion. Sometimes they could have this like on a weekly basis. Chelation therapy, which involves the administration of the antidote for iron poisoning. That's deferoxamine, deferrazirox, deferiprone. Okay, and of course, stem cell transplant. Okay, so let's try answering a question. Which of the following interventions are appropriate for patients with hallucination? Oh, sorry for that. Okay, that has been repeated. Okay. Okay, now let's move on to folic acid deficiency anemia. Okay, folic acid deficiency anemia is common in pregnant patients. Why? Especially those who don't eat green leafy vegetables. The recommended dietary allowance for pregnant patients for green leafy vegetables would be 400 micrograms a day. This is to prevent neural tube defects and folic acid deficiency anemia. Okay, so folic acid is the commercial form of folate, okay, but in its natural form, that is called your folate, and it's found in green leafy vegetables. So folate helps in the formation of red blood cells and reduction of neural tube defects. So if a patient will have folic acid deficiency anemia, or they're not eating green leafy vegetables in the desired amount that they are supposed to take, then that simply means that the patient's baby could be at risk for meningocele or myelomeningocele. Okay. So liver and liver products, including all types of pate, are rich in folic acid, should be avoided during pregnancy. Okay. So it's rich in folic acid. So it could be a source of folic acid to prevent folic acid deficiency anemia. Why is it to be avoided during pregnancy? Because of the risk for toxoplasmosis in meat and meat products. Remember, toxoplasmosis could be associated with the intake of canned meats and meat products like liver and liver products, as well as undercooked meat, and of course, your cat litter. So discarding the cat litter box is not an appropriate activity for the pregnant patients, including eating liver and liver products during pregnancy. Okay, let's try answering a sample question. Which of the following are good sources of folic acid for a pregnant client? Pay particular attention. If you have a pregnant client, okay, vegetarian pate, we put an X, any form of pate, whether liver or vegetarian pate, these are canned products and may contain your Toxoplasma gondii, which are the causative agent of your toxoplasmosis. Peas, yes. Broccoli, yes. Brussels sprouts, yes. Kidney beans, yes. Liver, no. Okay. Now, let's pay particular attention to atrial fibrillation. You know for a fact that in atrial fibrillation, the atria contracts, okay? um, for 250 beats or 400 beats per minute. So instead of the usual contraction, okay, strong contraction like this, it is just quivering. And this could lead to clot formation, blood stasis and clot formation that could lead to stroke. So if you'll be asked, which client is most at risk to stroke? Look for the client with atrial fibrillation. How would you know that you have atrial fibrillation? You have irregular QRS and small fibrillatory waves in lieu of the P waves, okay? So that's the reason why in patients with atrial fibrillation, okay, even before the patient will have a stroke, they will administer your anticoagulants like aspirin, heparin, dabigatran, pradaxa, okay? And then eventually the patient undergoes MRI to identify whether the patient is having stroke, because most clots that leads to stroke are cardiac in origin, okay? So let's try answering a sample question. Which of the following interventions are appropriate for a client with ECG tracing presented below? So what is difficult with this question is that it's not giving you the diagnosis. It's asking you to interpret an EKG. Okay, so which simply means that it's very, very important that you are able to interpret the client's EKG, okay, tracing. And what is important here is we have a video that simplifies EKG interpretation. We have two videos, one video for the pointers, that's I think just 30 minutes or less, and a video that's 1 hour, 38 minutes, which is very detailed. It is presented in such a way that you will remember it, and that is specific for those who are preparing for the NCLEX-RN. So I advise you to check out our video on EKG interpretation for nurses. Okay, so what happens therefore, take a look at this class. You have an irregular QRS. We say irregular because you don't have equal distances in between QRS. And then you have small P waves, your fibrillatory waves. Okay, now, when your patient is having atrial fibrillation, the atrial rate of contraction will be 250 to 400 beats per minute. So any drug that may increase heart contraction should not be given. Okay. Atropine sulfate increases cardiac contraction, like adenosine does, okay, like your milrinone does. That's why it's not given. It could worsen atrial fibrillation. Administration of warfarin sodium, yes, it dissolves, it prevents rather the enlargement of existing clots. It prevents the formation of clots, but it does not dissolve the clots, but it's necessary to prevent clot formation. The keyword is prevention. Administration of amiodarone, okay, yes, the patient is given that in order for the patient to be able to normalize the heart rhythm, okay. Cardioversion, yes. Cryotherapy, this is the administration of cold, okay, into the inner lining of the patient's atria, and this could lead to scar formation, like your ablation therapy. And once the walls are scarred, they are less sensitive to stimulation. Therefore, the heart rate now decreases, okay? So administration of epoetin alpha, this is your epogen, it increases red blood cells. So this could actually cause worsening of clot formation. Your epoetin alpha is given in clients with anemia secondary to chronic renal failure, okay? So that is not used in clients with atrial fibrillation. So this is how your atrial fibrillation differs from atrial flutter. In atrial fibrillation, you have irregular QRS. In atrial flutter, you have regular QRS, and the P waves are smaller. In atrial fibrillation, in atrial flutter, the P waves are larger. So notice also that there seem to be like two, okay, P waves in relation to one QRS. So the P to R ratio could be 2:1 in atrial flutter, okay. So now let's talk about hypermagnesemia. Now, what is important for you to remember about hypermagnesemia is that, okay, you begin with the normal level of magnesium, and it's 1.7 to 2.2 milligrams per deciliter. Now, your magnesium is primarily stored in the bones, and it helps maintain bone health, cardiovascular function, and neurotransmission. That's the reason why magnesium is used as a treatment of choice for patients with dorsado point. Again, you can actually watch our ECG video for you to be familiar with dorsado point and why magnesium is the treatment of choice, because dorsado point is usually associated with hypomagnesemia. Now, magnesium also helps in neurotransmission, and magnesium in the body is absorbed through the gastrointestinal tract, okay, and excreted in the urine. Therefore, the two organs responsible for maintaining the amount of magnesium in the body would be the gastrointestinal tract plus, okay, the kidneys, because the kidneys would be responsible for the excretion of the electrolyte. So let's try using what we learned to answer a sample question. Which of the following manifestations are found in hypermagnesemia? Select all that apply. Okay, so hypertension, no, we'll have hypotension. Flushing, yes. Headache, yes. Nausea, yes. Vomiting, yes. Hypoventilation, usually it's hyperventilation. So what are the manifestations of hypermagnesemia? It depends on the level. So above 0.3 to 7, you have flushing, nausea, and headache. So between 7 to 12, patient would feel extreme fatigue and low blood pressure. Above 12, there's going to be muscle paralysis and hyperventilation. And above 15.6, that could lead to coma. So excessive magnesium, therefore, could potentially affect the central nervous system. Okay? So the treatment of hypermagnesemia includes respiratory support, because the patient could have weak muscles that are necessary for breathing, and the administration of calcium gluconate, which is the antidote for magnesium sulfate. Okay, now let me now highlight what you need to remember related to the concept of burns, and this is about the rule of 9. Okay, so let's have a quick review for the adult body part. The head and neck is going to be 9%, but for infants, it's going to be 18. For older children, it's going to be 14. Each of the arm and each palm, so each of the arm is 9, each palm is 1.5. Perineum is 1, regardless of the size. The front trunk would be 18, the back trunk would be 18, so this 36. And then the legs would be 18 for the infant, 14 for the older children, 16. Okay, so here is a sample question. An adult client is admitted to the emergency room following a burn injury. The burn initially affected the client's upper half of the anterior torso, and there were circumferential burns to the lower half of both arms. So let's analyze this. The torso should be 18, but upper half, so that's going to be 9. Then lower half of both arms, so the entire arm would be 9. Lower half would just be 4.5, in both arms, that's going to be 9, so it's 18. Client's clothes caught on fire and the client ran, causing subsequent burn injuries to the entire face, okay? And the upper half of the posterior torso. So this is going to be 9, 9, and then 9, that's 27, and then just half of the head. So that's going to be 4.5. Using the rule of 9s, determine the extent of the burn injury. So that's going to be 31.5. It's going to be 9, 9 plus the back 9, 27 plus 4.5, because you just have half of the head. Okay. Now, for ventricular fibrillation, which is the most dangerous type of arrhythmia, once again, I advise you to check out my extended and comprehensive video that deals with the different types of arrhythmia. So let's talk about ventricular fibrillation. The priority goal of treatment in ventricular fibrillation is to restore blood flow to the brain and other organs. Okay, that's the priority. So here's a sample question. Which of the following interventions are appropriate for a client with ECG tracing presented below? Select all that apply. Okay, administration of atropine sulfate, no, it could potentially worsen, okay, your ventricular fibrillation. Administration of lidocaine, yes, in fact, that's a drug of choice. CPR, that's the immediate treatment that is done. That's your priority treatment, CPR. Use of automated external defibrillator. Yes, and don't forget the amount of electricity that's administered. For the first shock, it's 200 joules. Second shock, 200 to 300 joules. And the third shock, 360 joules. Then administration of epinephrine. Yes, okay. Administration of Synthroid. No, Synthroid is given in clients with hypothyroidism in the morning for the rest of the patient's life. This is a thyroid supplement, and it has the potential to cause palpitation and eventually lead to anginal pain or even the development of myocardial contraction. So it's not given in clients with ventricular fibrillation. Okay. So your ventricular tachycardia looks like this. That's how it's different from ventricular fibrillation. Once again, check out my EKG interpretation video to learn more about this. Okay, next. It's very important also that you have to know the steps on the use of cane, okay? So make sure that the length of cane is at the greater trochanter level. And then the arms, when you're holding the cane, should not be straight, should be flexed 15 to 30 degrees, okay? Now, you have to hold the cane on the area that you will need to press on, okay? Because you will need to push on the cane, okay, to obtain support. Okay, now, having that in mind, let's try answering a sample question. Which instruction is appropriate to provide a patient who will use a cane? Flex the elbow at 30 degrees, yes. Hold the cane 6 inches lateral to the base of the fifth toe, yes. The handle is approximately at the level of the greater trochanter, yes. Handle the cane in the affected side, no. It should be on the unaffected side so you can actually press on it as you try to walk. When going upstairs, step up on the unaffected leg, then place the cane and affected extremity on the step. Yes, remember, unaffected leg, then cane, then the affected extremity. So you can actually press on the cane as you move up. Okay. So this is a reminder to receive a PDF file of the essential aspects of this presentation. Okay, we're giving this for free and you can share it to your friends, do something good during this time of the pandemic so that we will all be blessed with the achievement of our greatest wish, which is to become a USRN. So send us an email at this address, mentor.raygapus@gmail.com. So let's learn together. For more instructional videos, subscribe to our YouTube channel, Gapus Mentors, and my Facebook page, Mentor Ray.